Good afternoon, friends. And we are really running short of time, so the niceties I can always take care of later. But like Shah Rukh Khan says, my name is Khan and I'm not a terrorist. I'm Manoj and I'm not a radiologist. I'm an ENT, a hardcore ENT specialist, like anyone sitting in the auditorium today. So let's get this out very fast and soon. This talk is not sponsored by any diagnostic pharmaceutical company, and therefore there's no conflict of interest. And all the images, the clinical images that you see here are part of my collection over the last 20 years, and therefore subject to copyright. Well, I stand in front of you today because of my family and because of this gentleman, Professor Mario Sana, who molded my philosophy in as far as lateral skull base is concerned. So thank you, Prof. You've always been there and you continue to be there. Now, before we go to the actual the presentation, the fact is that I was given the topic which said when to do and what to look for. I have just twisted it around, right? What I have done is what to look for, because if you know what to look for, you would know when to do it. So we'll think of the when to do it later on, and let's try and see what are the different pathologies, what are the different situations that we need to ascertain as far as either a CT or an MR of the temporal bone or the intracranial or the associated CP angle is concerned. So I'll go a little fast because I want to give you as much information through the images as possible. Right. Now, if you are an ENT specialist and you see something like this and your patient is complaining of dizziness, you do a CT, right? Why? Unsafe CSOM, dizziness. If you are expecting an intratemporal complication, for example, a fistulous communication, you do a CT first, and then probably the need for an MRI might arise, usually does not. But then if you're looking for an extratemporal or an intracranial complication, you just flip it around, you do an MR first, and then probably think of a CT. Why? Now, if your patient was something of the clinical picture that you saw, and the patient starts complaining of dizziness, sensorineural hearing loss, this is one very common pathology that you expect. That's the vestibule, that's the lateral semicircular canal, and as we can see that the labyrinthine bone on the lateral aspect of the lateral semicircular canal is eroded. Thereby, this is a frank lateral semicircular canal fistula, easily diagnosed. Not much of rocket science there. But if the same patient presents to you with a little bit of dimpling, please make sure that you still consider a lateral semicircular canal fistula, because a lot of CT scan, though they are termed HRCTs, they are actually not HRCTs. So unless and until your CT scan is a sub-millimeter acquisition, there is a chance that you might find a dimpling over the lateral semicircular canal region, but you might actually miss out a lateral semicircular canal fistula. So do ask for sub-millimeter cuts, but then if you do have dimpling, please do not ascertain it to be just an erosion. There could be an underlying fistula, right? Soman Curtin very clearly says that the conclusive diagnosis of a fistula on an HRCT is when you have a communication or the overlying bone erosion on 3 contiguous scans as far as the axial scan is concerned. Same patient, coronal scan, you can very well see that's the lateral semicircular canal, that's the area of the facial nerve, and the bone over the lateral semicircular canal is missing. Again, a lateral semicircular canal fistula. Patient complaining of dizziness, another patient on the other side, lateral semicircular canal, bone over the lateral semicircular canal missing with pathology in the attic and the adductus area, lateral semicircular canal fistula. But then is it always the lateral semicircular canal which is affected? Not necessarily. But then prior to that, what interestingly you can also find is the areas of hypointensity within the vestibule. What does that indicate? That indicates a nubal labyrinth, which means that the membranous labyrinth too has been compromised and air bubble has actually entered the labyrinth, and these patients are more liable to have a sensation of dizziness rather than aren't we taught that you take facial nerve to be dehiscent and the lateral canal to be fistulous? unless proven otherwise before you start a mastoid surgery. Why? Why is it that there is a fistulous communication but your patient never complained of a dizziness? That's because the chances of a patient complaining of a dizziness with a fistulous communication of the lateral canal is more when there is pneumolabyrinth rather than just a communication between the perilymph and the middle ear cavity. So if you have a pneumolabyrinth like this, all the more clear for you that your patient is having a frank lateral semicircular canal fistula. But then, as I said, is it always the lateral semicircular canal? No, my friends. Look at that. That's the superior semicircular canal, which has been eroded by this localized disease. It's not a petrous bone cholesteatoma. It's not an extensive petrous bone cholesteatoma. It's a small cholesteatoma in the attic region, eroding the tegmen and the superior semicircular canal. So that patient too would present to you as with dizziness, right? So right. So that was as far as the intratemporal bony compartment was concerned, correct? But now your patient is presenting with the dizziness part, and you need to know that whether the extratemporal component or the intracranial component is normal or not. So on a CT scan, if you see something like this, you can see the disease in the mastoid cavity, right? The other mastoid cavity is normal, but you see this rim of hyperintensity with hypointense shadow in between. That's a cerebellar abscess. This patient too will present to you with giddiness. Another example, look how the posterior plate over the petrous bone has been eroded, leading to a cerebellar abscess. Another patient, cerebellar abscess, right? So you have to understand what are you looking for, and therefore, what do you want to order? Is that all? No, we're not through with as far as the unsafe CSOM is concerned. If your patient is complaining of an unsafe CSOM and of giddiness, in spite of not having neck rigidity, in spite of not having high spiking temperature, as our older textbooks say,
Manoj enjoyed that presentation. Sunil Dutt here from Bangalore. Two questions I had very specifically. Slice thickness on your CT, you said sub-millimeter, 0.6?
0.5.
0.5.
Absolutely.
That's fantastic. And what about 3 Tesla MRI? Will that do better than going for gadolinium
No.
enhancement?
No, sir.
Go ahead.
Okay, shall I?
Yeah.
No, I thought there's something else that you would like to say.
I'll come back.
Right.
Yeah.
Given a choice, it should be 3T.
Yeah.
Right? Because the resolution is much better and we're looking at very, very fine structures. I mean, I don't have time. I can actually show you the modulus, right? And the basilar lamina on an MRI. I wish Dr. Pradeep had given me a little more time.
Yeah.
Anyway, the fact is, given it should be 3T with GAD, but given the option, though it's just a theoretical question, 1.5T with GAD, 3T without GAD, I'll do 1.5T with GAD. I will do GAD. Unless and until, obviously, there's a frank contraindication there. I will do with GAD. Full stop. Otherwise, Dr. Dutt, there is no way you can actually diagnose the intralabyrinthine and the smaller intracanalicular lesions, especially if they're towards the fundus, because the fundus is a crowded area. On a T1 or a T2, it could actually look black, and you might think it's a tumor, but the fundus is a much more crowded area compared to the porus acousticus. There's a little wider space, the nerves are a little wide apart, but the fundus by default is a crowded area, and you might mistake, either you might overdiagnose a tumor or you might miss.
Sure. Yeah. Okay. Like that.
So there is one more issue that we face, especially what I face is, the person actually comes with an MRI.
Right.
Already done MRI. And then you know that it is an inadequate MRI.
Correct.
So in case such a patient
I ask for
comes
it repeat.
You put your foot down and ask for it
absolutely. I tell them, I show them, obviously, with a certain rider, I tell them that, look, you've undergone a T1, T2, CIS, Fiesta, Flare. I'm not a radiologist, right? So, but in spite of that, if the contrast is missing, I would So if the contrast is missing, I would ask for, not contrast, GAD is missing, I would ask for a GAD enhanced MRI. Can I give you a small example, sir? Just a small example. Patient presents to me with right-sided sudden onset sensorineural loss, 45-year-old gentleman, right? Pure tone audiometry, unilateral perceptive loss. Give him steroid, responds totally. No symptom, right? Other than this faint disability, instability that the patient has. I ask for an MRI, and do you imagine? Can you even? I don't think you can actually imagine. Neither could I. What I landed up with. It was a posterior 1/3 perifalcine meningioma. Moral of the story: you don't know what your patient is actually carrying around. See, this patient, he had responded totally to the steroid, right? If I hadn't done that, if he had gone to some other doctor 2 years later for a slightly different symptom, say for example headache, and had the MRI done and there was this perifalcine meningioma, he would blame it on me. Watch your back. Watch your back. It's a difficult world.
My problem goes beyond this. VNG done, investigation, MRI done, with GAD done, no obvious pathology, structural lesion, but the patient is still there with the same problem. We have to go beyond this.
Okay, just 1 minute. I actually wanted to end the presentation in a different manner. Sir Isaac Newton, right? The man with the gravity and the laws of motion, he was considered a giant in his field. So when he was being knighted, he said that I am like a small child on the seashore playing with pebbles while the vast ocean of knowledge remains uncharted, unexplored before me. Even radiology is evolving. We do not have complete data as far as functional radiology is concerned. That's an evolving science, right? So whatever is possible has been done, and whatever is impossible will be done. So. Absolutely, sir. Absolutely.
Thing which I like to just highlight before you conclude. There are patients which we often get of sudden sensorineural hearing loss. They may or may not have vestibular symptoms. What is your opinion about getting the MRI done?
Every patient. Every patient. Every
The
patient.
MRI man.
Scan man.
Scan man.
One small example, last example, please. Lady, 7 years she had profound deafness in 1 year. With all due respect, that lady was seen here also, in Vizag, in Hyderabad, in Jaipur. 7 years. Every doctor said, आपका कान का नस सूख गया है, कुछ नहीं होगा, आराम से जिंदगी जी लीजिए. Sorry for sounding arrogant. The first time that she came to me, I do my audiometries on my own. I did the audiogram. And then I asked for an MR GAD. She had a 5 centimeter vestibular schwannoma. I don't have it here. I could have shown it to you. Unilateral, profound perceptive loss, 7 years. Imagine if she had had the scan 7 years ago. Is it necessary that it would have been 5 centimeters then? Are we not liable for it? Absolutely. Unilateral loss, sudden onset, chronic, gradual, doesn't matter. Unilateral perceptive loss, please do an MR with GAD. No, 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 no. You do your clinical examination. Again, I'm probably falling into a trap that you're creating for me, correct? So the fact is that no, I would not. But then if I'm not finding anything initially, I sometimes refer them to the neurologist and let them come back to me. Because honestly, I can't do a fundoscopy. I cannot interpret the retina even to save my life. But what if the neurologist does a fundoscopy, a retinoscopy, and sees something and takes it forward from there? Which is insufficient, and that is where Dr. Srinivas's question becomes relevant. Most of the patients who come to me have already been to a neurologist where they have undergone a screening MRI. So I ask them to get it done again.